On behalf of IHPBA Indian chapter, I welcome you all in this today's lecture. And our topic today is expanding the liver donor pool, current perspectives. So I'll introduce the topic first, then we'll talk about the aim of expanding liver pool, then extended criteria donor in disease donor liver transplant, then for living donor liver transplant, and then we'll talk about machine perfusion, and then conclusion. So liver transplant is an established treatment for end-stage liver disease. Disease donor liver transplant is being done for more than 5 decades, and living donor liver transplant is done for more than 3 decades now. The need for liver transplant is increasing, and hence we need more and more organs. To expand the potential donor pool, more and more marginal or extended criteria donors have to be used. So donors are generally considered marginal if they are likely to cause initial poor function or primary non-function of the graft. Although the organs from the marginal donors may not be optimal, they are very viable alternative to do the transplant. It is better than taking a little bit of the risk rather than dying on the waiting list, waiting for the suitable liver. The combination of the multiple marginal factors seems to be additive, and this knowledge is very, very important. And hence, when we consider one particular donor for transplant, we have to take into account all the factors, and then we have to decide whether that liver can be used or not. So what is an ideal donor? The ideal donor does not exist very often. So ideal donor is the one which is very young, trauma is a cause of death, hemodynamically stable, duration in the hospital is short, and no other adverse factor. The quality of the liver is good, there is no fat content, and all of the parameters are in the acceptable range. Now, when you have a potential donor in front of you, at least 1 or 2 criteria are not ideal. So either you have to optimize them, or then you have to put all the factors together and then decide whether that liver can be used or not. But the aim is to use every available organ and give an opportunity of liver transplant to the needy patient. So the aim of expanding liver pool is to make liver available for more and more patients, and thus avoid mortality on the waiting list. Better understanding of the selection and allocation of liver makes sure that the patient and the graft survival is better, and aim is to use every possible available organ. So these are the various extended criteria donors, especially in case of disease donor liver transplant, and each of this we are going to discuss in subsequent part of this talk. So elderly donors, steatotic liver, hypernatremia, and so forth and so on. We'll also talk about split liver transplant and use of machine perfusion to identify correct donor liver. If you try to expand extended criteria donors in case of living donor liver transplant, so basically ABO incompatible livers, domino livers, dual lobe liver transplant. Swap liver transplant is also a way to expand liver donor pool, and unrelated donors in some countries where it is lawfully possible. So if we talk about age of the potential donor, so there is no absolute age beyond which a liver cannot be used. No liver should be discarded or rejected just on the basis of age. Over the years, the mean age of the donor has gone up because more and more elderly donors are used. Excellent graft survival, even in octogenarian, that is the donors of 80 plus age, have been noticed, and that's why the age should not be the criteria. However, in many guidelines in many countries, 65 years of age is the arbitrary cutoff line, above which you have to be careful and see that there are no other risk factor also. And if you feel that the liver is likely to work, then that liver should be used. So what is the mechanism by which these elderly donors are slightly at higher risk compared to the younger ones? So liver is more immune to the age compared to other organs, and that is the advantage we have to take here. Now, liver has the large functional reserve, regenerative capacity, and dual blood supply. Older donor livers tend to be slightly smaller, darker, and may have slightly more fibrous element. Older donor livers are more susceptible to endothelial injury from cold ischemia, and it may show decreased ATP synthesis after reperfusion, and this may lead to some injury after reperfusion. When you consider for clinical use, the experience is that a greater degree of delayed function may occur if the liver is of inferior quality. The cholestatic pattern of liver function tests may be observed after transplant. There is a tendency to have slightly higher levels of bilirubin and prothrombin time after transplant. Pre-perfusion biopsies of the liver from donors more than 60 years show there is higher rate of steatosis compared to the younger ones. Older livers may be more susceptible to endothelial injury during cold ischemia, and this is something which we have to take into account, and hence we have to try to keep the cold ischemia time less than 8 hours. If you do that, then this adverse factor is nullified to a large extent. Successful use of elderly livers, about 70 and 80 years have been used, and hence I again utter that age should not be the only criteria by which you reject the organs. Elderly liver and hepatitis C is a deadly combination, and one has to be careful. More than 60 years of age and HCV positive status, one should be very, very careful before utilizing that liver because of the very high incidence of associated fibrosis. But if in doubt, want to use that liver, the biopsy is recommended before the use. Elderly donors are also likely to have a higher incidence of the hepatic artery thrombosis after transplant. Steatosis is another very important factor which affects donor liver. Now, steatosis are of two types: microvesicular steatosis and macrovesicular steatosis. The microvesicular steatosis does not affect the graft function to greater extent, and it is the macrovesicular steatosis that is very important. The incidence of macrovesicular steatosis increases with the increasing use of alcohol, obesity, age, and the presence of type 2 diabetes mellitus. Histologically, it's very easy to identify macrosteatosis. Here we can see the difference between the normal liver and the macrosteatosis, and the extent of steatosis is also very important. Apart from histology, sonography and CT scan also indicates the level of steatosis. So how steatosis affects the liver function after transplant? So underlying mechanisms are impaired metabolism in case of steatotic hepatocytes. The physical effects of the lipid during cold ischemia is detrimental: diminished portal blood flow in steatotic liver, increased sensitivity to oxidative stress on reperfusion, and steatotic livers have been associated with raised sensitivity to endotoxins. So these all put together increases the risk after transplant if the steatosis is of very high grade level. So these are the various mechanisms by which ischemia reperfusion occurs and injury occurs in steatotic liver. So microcirculation of the liver gets deteriorated, free oxygen radicals are formed, and they also affect liver. At the same time, the liver mitochondrial function and the plasma membrane fluidity are altered in case of steatotic liver. Any extent of microsteatosis is acceptable. Mild steatosis, that is 5 to 30%, is acceptable. Less than 5% is considered normal. Moderate steatosis can be accepted in very, very select group of patients where other factors are not there and the donor recipient is otherwise stable and the cold ischemia time is very, very less. Serious steatosis, that is more than 60% of fat content, are usually rejected in view of very high incidence of primary non-function or direct non-function. Liver biopsy is must before discarding the liver. Any level of fibrosis should not be accepted, and the biopsy should not increase the cold ischemia time, and there should be a mechanism and the logistics should be available to do the liver biopsy as quickly as possible in the emergency. Some degree of hyperbilirubemia and transaminisemia are accepted and expected also after the use of steatotic liver. The steatosis disappears after transplant in few weeks' time, especially if it is less than 30%. If it is more, then it may not disappear completely or may take a longer time. Moderate to severe steatosis are used occasionally where the patient is in dire need of an organ and the other organ is not available. However, in such a situation, the cold ischemia time should be kept to bare minimum and the donor should be otherwise stable. Machine perfusion helps you identify the liver which is likely to work and the liver which is likely to cause problems after transplant. The donor sodium level is also another very important factor. So donor hypernatremia, because of the diabetes insipidus and the pathophysiology of brain death leads to rise in the donor sodium level, and the various accepted range varying from 155 to 170 have been described in the literature. However, the current consensus is no sodium level is an absolute contraindication. If the donor is hemodynamically stable, a time should be utilized to improve the sodium level in donor and then utilize the liver. Both the donor and the recipient sodium levels are important. Recipients usually have low sodium levels and donors have high sodium level. It is usually the difference between the two sodium levels in donor and recipient, which is that absolute difference which is more important than the absolute level itself. So, though the retrospective analysis is observed that the donor hypernatremia does not matter, basically, if you have time should be utilized to correct the hypernatremia and effort should be made to bring the level down below 155. So this is another retrospective analysis, and that suggests that even in high level of hypernatremia, it is the preservation solution which rectifies the high level and does not lead to detrimental effect after transplant. So these are the various reports. None of them is randomized control trial. They are retrospective analysis and the assessments done on a retrospective manner. Another consideration is donors from those who have positive viral serology. So the potential donors with positive viral serology should not be completely excluded, and they should be considered for those who are already infected with the said agent or the recipient is very, very critical. And if these organs are used, then the consent and the counseling are very important. It is the hepatitis B core antigen positivity, HBS positivity, SPAG positivity, hepatitis C virus antibody positivity, and the HIV positivity. These are the four situations we are talking about. So if you talk about hepatitis B, the small proportion of liver donors are anti-HBC positive, and it is the elderly people with HBC positive, which is a deadly combination, and one has to be very careful before you can consider this combination. Otherwise, just anti-HBC positivity is fine. When such donor is used, the first it is offered to those who are HbSAg positive. If they are not available, then they are offered to those who have demonstrated presence of anti-HbS positive antibody. So these are the patients who don't require prophylaxis because they are protected because of the presence of this antibody. And finally, they are given to HBV negative recipients, but this is a very debatable aspect. In case of critical conditions where lifelong prophylaxis is mandatory, and hence, as far as possible, it is used for one of the first two situations. Post liver transplant hepatitis B vaccine prophylaxis is debatable. It is the donor with a positive anti-HBs antibodies don't require any prophylaxis. Various case series have been reported where knowingly or accidentally hepatitis B positive donor was utilized in hepatitis B negative recipients, and many times it was seen that either HBs AG clearance occurs, or in spite of use of positive donor, the recipient does not show the signs of development of hepatitis, or they are given prophylaxis and virus replication is prevented. Many times, even the virus replication is also not seen in this case, even in absence of prophylaxis. So, though it should not be knowingly used in those who are hepatitis B negative, if it is accidentally used, then the prophylaxis can prevent the development of hepatitis B related liver problem after transplant. The incidence of hepatitis C in donor as well as recipient is reducing. The need of transplant in hepatitis C is also going to be reducing now because of the availability of the newer modalities, and hence the more and more hepatitis C is cured without transplant, and the incidence of hepatitis C in donor is also reducing. However, with availability, whenever the donor has hepatitis C status, then it should be used in hepatitis positive, C positive recipient. The time to recurrence in the course of HCV after transplant is more or less same for those who received hepatitis C positive donors compared to those who had hepatitis C negative donors. So the hepatitis C recipient does not show any difference whether their liver had hepatitis C positive or not. Studies also found no difference in either patient survival, graft survival, the incidence, timing, and severity of recurrent HCV in those who had hepatitis positive grafts and hepatitis positive recipients. So, if you talk about donors with hepatitis C positivity, most under 50 are usable. Between the age of 50 and 60, 50% are usable, while above 60 years, most are not usable because of the presence of associated fibrosis. The viral genotype has no much significance, and hence the genotype in donor should not be given any unnecessary importance. Livers from donors with active ongoing hepatitis and fibrosis should not be used, and the scoring system has been derived in order to aid the decision to decide whether that particular liver can be used or not. So this is another retrospective study which has shown the effect of use of hepatitis C positive donor. The concern that transplantation of organs from HIV remains high in most countries. HIV positive donors have been excluded in most countries over the years, and this leads to the loss of good number of potential organ donors. At the same time, HIV positive solid organ transplant candidates remain at disadvantage because they don't get liver easily. Transmission of a new HIV strain to an immunosuppressed HIV positive recipient is also another risk factor. So, having this background, if we consider clinically how do we use HIV positive donor, so the most organs from HIV positive disease donors are used, if at all, are for the HIV positive recipients. At times, there are donors who have history of high risk behavior, and even if the donor has high risk behavior history, like positive prostitution history, drug abuse, homosexuality, multiple transfusion, etc., the organ must be used as far as possible. The recipient should be screened after 3 months, and if they are found to have viral infection, then they should be treated accordingly. But just because of the history of high risk behavior, the organ should not be discarded. Now, the risk of transmission of the bacterial infection from the donor to the recipient is low, but is a theoretical possibility and does not represent a very, very high risk factor for liver graft failure. So, it is recommended to use directed antibiotic prophylaxis in donor before the use of liver. As many doses are possible should be given to the donor before the organs are retrieved. And even the antibiotic, when the antibiotics are given, it does not completely eliminate the risk of transmission of infection, but it is manageable. If a recipient shows high-grade fever or positive culture, then they should also be given a high dose of appropriate antibiotics, and it should be taken care of. Transmission of the bacterial and the fungal infection to the recipient are usually from the respiratory and the urinary tracts. The donors with a documented bacterial meningitis can be used and does not preclude transplant, but the appropriate antibiotic use is very, very much necessary. And undefined CNS infections are probably at risk of transmitting infection, but again, culture and sensitivity and appropriate use of antibiotics will take care of this. The presence of infective endocarditis in donor does not preclude the donation. However, prolonged pathogen-directed antimicrobial therapy is very, very. Non-heart-beating donors is a great value addition over the last few years, and more and more countries are allowing this now lawfully. Now, non-heart-beating donors increases and adds 10 to 20% of organs. Of course, the quality of organs are slightly inferior to the brain-dead heart-beating donors due to high incidence of the ischemic injury to the organ. Now, if the donor is young, there is absence of steatosis, if you have a short warm ischemia time and reasonable cold ischemia time, then the organ can be preserved in good condition and can give very good results. Non-heart beating donors are of two types, controlled and uncontrolled. In case of controlled heart beating donors, they undergo circulatory arrest following planned withdrawal of the life support systems, with the donor team ready to treat in the theater, and they retrieve organs immediately, keeping the warm ischemia time as short as possible. While uncontrolled non-heart beating donors are the donors who had unplanned cardiac arrest and then they had organ retrieved. So the controlled non-heart beating donors have slightly better organs which are in a well-preserved condition compared to those who had uncontrolled non-heart beating situation. Warm ischemia time should be kept less than 30 minutes. It is considered between the time from the blood pressure of less than 15 millimeter of mercury and the aortic perfusion. Cold ischemia type should also be kept to minimum, and organ should be utilized as soon as possible. Any additional risk factor has adverse effect and should be avoided. Heart beating and non-heart beating donors, when compared, obviously non-heart beating donors are slightly inferior. However, they provide a very good source of additional organs and gives an opportunity to 10 to 20% of extra patient for transplant. Now, a patient who is a donor who has died of trauma may have associated liver trauma also, but that does not rule out the possibility of the use of that damaged liver for transplant. So that depends on the extent and the position of liver injury and how hemodynamically stable the patient is. Either the whole liver or the part of the liver can be utilized after discarding the damaged portion, and a successful transplant has been reported in the literature. Though this is not a very, very common situation, this is also another very important aspect that one must have kept in mind, especially in the level 1 trauma centers where livers can be utilized for transplant. Now, donors could have known or unknown malignancy, and there remains theoretical risk of transmitting this malignancy to the recipient. So, with the rise in the donor age, the incidence of malignancy in the donor has also increased. The incidence of malignancy in donor is approximately 3%, and the incidence of transmission of malignancy is very low, but is not zero. The most frequently transmitted malignancies originate from CNS malignancy, melanoma, renal cell carcinoma, lung carcinoma. These are the tumors which are easily transmitted to the recipient. Extremely high rate of transmission is in melanoma, choriocarcinoma, lung cancers. So these all are absolute contraindications. So donors with low-grade malignancy which are treated long ago. So this includes skin tumors except melanoma. Or the donors with low-grade cancers from CNS, and these are the ones which are considered for donation. Certain histologies of CNS tumors like glioblastoma multiforme, astrocytoma, and medulloblastoma, especially grade 3 and 4, are contraindications. Similarly, those patients who have history of ventricular shunting, major craniotomy, or extensive radiation for malignancy are contraindication for donation. History of melanoma, choriocarcinoma, lymphoma, carcinoma of breast, carcinoma lung, kidney, and colon. These have very, very high rate of cancer transmission in spite of long period of cancer-free survival. Similarly, the tumors that possess the potential of unpredictable recurrence and the metastatic malignancy should also be avoided for donation. So low-grade skin malignancy, low-grade CNS tumors, and those tumors which are treated very many years ago and have very low tendency of recurrence are the ones who are considered for donation. Those patients who receive organs from donors with malignancy, over immunosuppression may lead to accelerated growth of the tumor, and hence immunosuppression modulation is must after transplant. The next consideration is how the cause and the duration of the brain death affects the liver and how it influences the decision to accept or reject the donor liver. Now, brain death induces a profound inflammatory response affecting the quality and function of the donor organs, and it has been presumed that a longer brain death duration increases injury to the donor organs. Upregulation of the defense mechanism also occurs and initiates regeneration and repair of the organs. So, in case of brain death, initially for some time there is ongoing damage to the organ, and then there is some recovery, and this all should be taken into account. And that's why this understanding poses the choice whether the retrieval should be as soon as possible, or one should give some time for organs to recover from initial insult. A retrospective study from UK has demonstrated that prolonged brain death is no longer considered detrimental as far as the outcome in the abdominal organ transplantation is considered. Similarly, this analysis renounces that there is no need to rush and retrieve. It is better to improve the quality of the organs and stabilize the donor, improve sodium level, improve infection, evaluate organs properly, have enough time to prepare recipients, and then retrieve the organs. So the situation of the brain death is not as hostile as it was perceived in the past. Though the cause of the brain death has no direct influence on the selection of the organ, it is observed that the quality of the organs are likely to be better where the cause of brain death is injury rather than hemorrhage. This is possibly because the head injury patients are likely to be younger and have less comorbidities compared to those who had intracranial hemorrhage. When you have a patient in the ICU, it is very important that the hemodynamical stability are maintained, and this decides how well the organs are perfused. So hemodynamic instability is common in any brain dead person, and most of these patients need vasoactive supports in varying doses to maintain the mean arterial blood pressure. But just the presence of this vasoactive substance is not important. The dose and the number of inotropes is not important. It is how well the mean arterial blood pressure is maintained is important. Whenever in doubt about the ischemic insult to the uh, solid organ or liver because of hemodynamic instability or history of cardiac arrest, one must do liver biopsy rather than just discarding organ on the basis of history. Duration of brain dead person in hospital or in ICU. The absolute duration is not important. However, in view of increasing organ scarcity, the duration is now not given importance, and there is an effort to use more and more organs from every available donor. However, what is most important is, rather than duration, how stable that donor has been during the hospital and ICU stay. As far as possible, the donors are identified and the organs are allocated to the recipients who are compatible from a blood group point of view. However, there are situations where either the recipient is in dire emergency or the suitable recipient is not available. The, to avoid wastage of organ, ABO incompatibility transplants are done. This is also done in living donor liver transplant as a planned procedure where you don't have any other suitable blood group matched donor available in the family. So in liver transplant, ABO incompatible liver grafts have been used over a period of time. Now, of the major phenotype with the blood group A, there are two subtypes, A1 and A2, and it is the A2 which does not react too much to B sera, and hence the lower cell surface expression of A antigen in A2 has shown to be utilizable and less problematic after transplant. So usually ABO incompatible transplants in cadaverous liver transplant scenario is done when the emergency organ availability is there, especially in case of acute liver failure or acute and chronic liver failure, or rescue transplants are necessary after non-function of the first transplant, or complication after transplant for things like hepatic artery thrombosis and similar other situations. Now, outcome after ABO incompatible liver transplant using disease donor liver transplant has been variable and disappointing because of the reported poor graft function, early graft loss, and increased rate of complication and vascular complication. And this is because here the possibility of preparing a recipient like ABO incompatible liver transplant in living donor liver transplant is not there. So things like rituximab and preoperative plasmapheresis have been utilized to reduce the immunogenic response post-transplant, and this provides superior graft and patient survival after transplant. Now, many times the potential donor in ICU shows slightly abnormal liver function tests. Now, how significant they are and how they should be interpreted, and how do we decide whether that liver can be used or not? Now, liver procurement should not be excluded just on the basis of slightly deranged liver function tests, because the common indications and the causes of abnormal liver function tests in a potential donor is hemodynamic instability because of the brainstem death situation, steatosis, sepsis, and underlying liver disease. There is no clear upper limit of transaminases above which liver cannot be used. So it is the history, hemodynamic stability, trend, and extent of deranged liver function, whether they are improving or not, whether there is recovery or not, and whether there is associated change in parameters like serum creatinine or not. This all directly and indirectly tells you how significant the liver has been affected. One must also rule out underlying liver disease when there are altered liver function tests like alcohol abuse, underlying chronic liver disease, or a non-alcoholic steatohepatitis and autoimmune liver disease. If the liver is enlarged and there is hyperechogenicity on sonography, there should be suspicion of steatosis. So whenever there is doubt because of deranged liver functions in a potential donor, one must do liver biopsy and quantify the underlying damage, and then one has an easier job to do, and effort should be to accept the liver as far as possible and allocate to the most appropriate recipient. Now, the duration of the cold ischemia time has been quoted from very short time to as long as 15 hours. However, shorter the better. The liver graft from elderly donors and or donors with steatosis are affected adversely by longer cold ischemia time, and effort should be made to keep it less than 8 hours. UW solution allows you to have slightly longer cold ischemia time compared to custodial or HTK solution. Now, in case of scarce availability of organs, split liver transplant is being used, where one good quality liver is divided into two and then given to either two adults or one adult and one pediatric recipients. So this is a great effort and a tool to increase the potential liver pool. So splitting is not possible in every organ, but should be considered where the liver is of good quality, the weight of a person is more than 40, age is less than 50, there is hardly any steatosis, the hemodynamic stability is great, no other adverse factors, other parameters normal, quality of organ looks good, the anatomy looks good, and the anatomy of the vessels are technically not hampering. So this is the picture of ex situ split. So this is one left lateral segment for pediatric and the rest of the liver for the adult patient. This is in situ split, where like living donor liver transplant, liver gets divided into two and then both the parts are given to the respective recipients. So split liver transplant involves dividing the diseased liver into two parts. The rationale is to reduce or prevent mortality on the pediatric waiting list also, without compromising the adult graft availability. It reduces the waiting times and it prevents the deterioration of the adult patient on the waiting list. In elective cases, the split liver transplant gives a very good result. The incidence of the vascular and biliary complications is slightly higher. However, they are of acceptable range if the procedure is done by an expert. Logistics and technical challenges are there, and it's difficult in a new center. However, in an established center with a good number of surgeons in the team, this is a viable and feasible option in selected livers. The most important factor is the liver vasculobiliary anatomy. During splitting, it is very important to ensure that both the grafts get good vessels and good biliary system. Therefore, the two grafts derived from one liver need to provide two major features: appropriate volume and appropriate function, inflow and outflow in both the recipients. Liver can be split in a planned fashion, and classical splitting produces left lateral graft where the left lateral segment is given to child and the remaining liver is given to an adult. In living donor liver transplant setup, many times the available donor from the family has available liver volume which is not enough for the recipient. However, two such donors from the family can give small portions of their liver, and both these small portions together can suffice the need of the large recipient of the family. And this is how donor pool can be expanded in living donor liver transplant. However, now the understanding is if one donor can provide weight of graft up to 650 grams, it may be enough for most of the recipients. However, if the GRWR is too low, dual dose liver transplant is a viable option. It is technically challenging, and very few centers across the world do it routinely. Many times, there may be two living donor liver transplant pairs. Both have suitable donors or a fit donor in the family, but because of either the volume or the blood group, they are not usable for their own family member. Such two pairs can exchange their grafts, and this is a swap liver transplant, and this is another way of expanding donor pool. So swap transplantation is a method of matching two pairs and exchanging their grafts and do the transplants in both the recipients. The success of liver transplantation gave good thrust to swap liver transplant also. So this is how both the pairs swap their donors. Many times multiple pairs are there, and the whole swap liver transplant chain is done. However, this includes too many operations at a time, and it is not easy to do so many operations at one point in time. In case of swap liver transplant, it's very important that all the transplants are done at the same time, because then the possibility of one donor backing out after his or her recipient is already operated and has received transplant from other pair, that theoretical possibility is not there. These are the various situations and types by which a swap liver transplants are done and the donor livers are swapped. A domino liver transplant is a type of transplant that occurs when a liver needs to be replaced in one person, but this liver can be used in another person. Domino liver transplants are rarely performed, but they provide a good option to increase the number of livers for transplant. So a person with, say for example, amyloidosis receive a healthy liver, but this person with amyloidosis gives his liver to another slightly older recipient who would have a good effect of this liver in his body. And before this liver has detrimental effect in new, slightly older recipient, the utility of the liver is already over. So in a domino liver transplant, you receive a liver from donor who has familial amyloidosis. The donor will receive a liver transplant to treat his or her condition, and the donor can then give his or her liver to you in a domino liver transplant, because the liver still can function. The liver that donor receives could be from living donor or a cadaver donor. So this is the diagrammatic depiction of the same thing. Now, machine perfusion is something which is utilized to test whether the liver will work properly or not. It also helps you buy some time. It also helps you make the emergency situation a semi-emergency situation. So grafts that fulfill extended criteria associated with increased allograft dysfunction and biliary complications, the newer machine perfusion systems have been developed to improve the outcomes with such borderline grafts. The precise understanding of the pathophysiology of tissue injury and understanding of unique events that happen at cellular level at each phase has helped in modifying the technique of organ retrieval, modification in the cold preservation solution, employment of the washout strategy, and newer machine perfusion devices. So these are the various protocols. According to temperature, it could be hypothermic, subhypothermic, or normothermic. Flows could be either pulsatile or non-pulsatile. It could be a single perfusion or dual perfusion, or it can be a perfused solution composition. These are the various protocols, and they are used in permutation and combination. The advantage of machine perfusion, as I said, maintains the patency of the vascular bed, provides the nutrients and low demand oxygen to support reduced energy demands, removal of the metabolic byproducts and toxins, provision of the access for administration of agents to enhance the viability, objective confirmation of organ viability, change from emergency to semi-elective surgery, and improved stabilization or rescue for extended criteria donor organs. So this is the picture of one of such machines. So with this, I would like to conclude that systemic liberalization of graft acceptance criteria provides an immediate expansion of the donor pool with acceptable graft and patient survival. This also avoids futile transplants. There is no age limit to be an organ donor. However, elderly donors should be avoided in presence of too many other risk factors. Mild macrosteatosis in liver is acceptable. Moderate macrosteatosis grafts have been successfully used for liver transplant in carefully selected recipients. Both donor sodium level as well as recipient sodium level is important. Although no graft should be rejected just on the basis of hypernatremia, if the donor is stable, it is desirable to correct the sodium level to level below 155 milliequivalent per ml. Potential donors with positive serology should not be completely excluded. Donors with positive hepatitis B status should be used for hepatitis B patients. Those with HBS, anti-HBS antibodies present has no risk of transmitting hepatitis B. HCV positive donors should be used for HCV positive recipients. Most organs from HIV positive disease donors are used for HIV positive recipients only. Risk of transmitting bacterial infection is low. The antibiotic use is must in donor as well as in recipient. Donors with infective endocarditis can be used. Non-heart beating donors increases the donor pool by 10 to 20%. In these cases, the warm ischemia time should be kept less than 30 minutes. No liver should be written off just because it's a traumatized liver. The whole or the reduced graft after discarding the damaged part can be used for transplant. And there are reports where such successful transplants have been done. Donors with low-grade malignancy treated many years ago and have very low incidence of recurrence can be used for donation. Superior graft and patient survival is observed even in ABO-incompatible liver transplant with the use of rituximab and plasmapheresis. Liver procurement should not be excluded only on the basis of just deranged liver functions. Split liver transplantation has been significant advantage to expand the high quality donor pool. In elective cases, split liver transplantation gives results similar to those who receive the whole organ. Dual lobe liver transplant, swap transplant, dominal liver transplant, and use of unrelated donors are useful strategies to expand donor pool. Thank you very much. And I hope this talk was helpful. And I've tried to summarize most of the aspects which can help us increase the donor pool in cadaver as well as living donor scenario. Thank you very much.